We go with the next participant, Mr. John Musonda, under clinical research. The topic would be patient satisfaction with non-pharmacological pain management during labor in an obstetric midwife unit of Peri-Urban Health District, South Africa.
Mr. Yeah, good afternoon. Thank you very much. Let me see if I can share my slide.
Yes, we can view a presentation. Can you please make it as a slideshow?
Yes. There we are.
Yes, Mr. John, you're good to go.
Just a minute. Yeah, my name is John Musonda. I'm a family medicine physician. I'm not supposed to be doing this yet. Sorry about that. Yeah, my name is John Musonda. I'm a family medicine physician. And I'm also on the faculty of family medicine in Wits, the University of Witwatersrand in Johannesburg, where I'm involved in supervising undergraduates and postgraduate medical students. I'm also a hospital administrator. I'm very much involved as clinical director in several hospitals in my area, as well as I'm finalizing my PhD with Texila. So the study I'm discussing is one where I have a co-author who did much of the data collection and while I supervised the study. Yeah, so in the form of introduction, the 2020 International Association of Study of Pain, they defined pain as an unpleasant sensory and emotional experience. So there's emotions attached to pain, and there's tissue damage, and it is described in such terms of control. The pain control is vital for quality health care. And we noticed that both drug and non-drug interventions, here we are calling them non-pharmacological interventions, improve the labor experience and is supported by evidence. In labor, pain is measured using several pain assessment scales, which are quite subjective. You know, you have the visual analog, you have the numerical, you have the brief pain inventory, you have the Wong-Barker, you have the British Pain Society pain rating, you have pain quality assessment, and McGill pain assessment, questionnaire short forms. All these scales all over the world are used to manage pain or to assess the severity of pain. You find that the British here are represented, the Canadians represented, and other parts of the world. So we all use one or the other form of pain control or pain assessment using this. So then we evaluated patient satisfaction. We wanted to see our own satisfaction in terms of the non-pharmacological pain treatment options, which they experienced in labor, in a midwife obstetric unit at Community Health Center in a peri-urban South Africa. What a midwife obstetric unit does is that it runs 24 hours and has got full-time midwives, not necessarily supported by the doctors because they are much more experienced and they manage these cases on their own. And they are really at the level of the community, in that they are not a district hospital, they are below a district hospital, and they are placed in the community. And in this case, we looked at the center, which is within in the eastern part of Johannesburg, which is actually a peri-urban area. So the aim was to assess patient satisfaction with the labor pain management treatment options in the unit, as I said. We described the objectives were to describe the social demographic severity of pain experience, proportion of satisfied patients, and also to determine associations between social demographics and the patient satisfaction. So this is really a study around quality of care that we give. So we then asked, what were the patient's non-pharmacological treatment options regarding coping and managing of labor pains? And what was the pain relief of those options? Then we also wanted to know what proportion of women were satisfied with the non-pharmacological treatment options. We hypothesized that women coped and managed birthing pains well, despite lack of anesthesia and analgesia by practicing non-pharmacological treatment options. This was a descriptive cross-sectional study conducted June 27 to March 2019 and reviewed 311 women. We used the patient satisfaction and American Pain Society pain outcome questionnaires, which we adapted in order to collect this data. The mean age was 26.9 years, and 90% were Black. And in that area, there's a predominance of a language called isiZulu. So they were actually isiZulu speakers, and with 2 children and some secondary education. Moderate pain was experienced in 49.9% of participants. Effective pain relief was demonstrated in 53.9%, while satisfaction was 56.3%. The only statistical significant predictor of dissatisfaction was number of live births, which have the p-value of 0.003. 1 live birth compared to 4 live births were more likely to be dissatisfied. Odds ratio 11.5 at 95% confidence interval. The findings then did suggest and they confirmed that non-pharmacological interventions were effective in managing labor pain at community level. Now, what we want to see is, so then why did we do all this? What was the problem? The South Africa provides free medical services to all pregnant women at primary care levels at hospitals to ensure access of all pregnant women for safe delivery. The issues of maternal mortalities across Africa, which are not improving, they're becoming worse. So not only that, we should now be looking at what quality do we offer, to our mothers, and pain control is one of such things. The use of anesthesia was not common it was not commonly practiced at the center, which we in our area and the community, and we hardly ever offered that. This is despite the South African maternal guidelines, which actually the 2020 version is the latest, spells out that when women are in labor and unless they are contraindicated, they should be given some analgesics. But in this case, we never saw that happening, and that prompted us to look into the extent of the problem. It seemed that there existed other problems with regards to pain relief in labor at this center. More research then we thought was needed at this stage, and there was no genuine reason why analgesics could not be given, because it was not a problem of availability. Drugs are available, and we just don't understand why these painkillers were not given. Judging by the excruciating pain experienced by mothers or these women when in labor, it was assumed that either the patients themselves had forgotten to ask for the analgesia, or they did not know about it, because it was quite surprising that they should go through that pain visibly, yet all these things were available. So the side map there shows where South Africa is in relation to the rest of the world. Is at the tip of Africa there. And yeah, that's where we are. And then what methods did we employ? As mentioned in the summaries, descriptive cross-sectional study between that period. Women who had normal vaginal delivery at Polapa Community Health Center. This is a community health center which delivers over 2,000 mothers a day, a month, as long as they are They don't have complication. They are normal vaginal deliveries. They're delivered at that center. It is supported by a regional hospital and a district hospital in the area, but it's within the community. And these mothers were reviewed 3 days after they delivered, because we wanted them to have settled down, and they were conveniently then sampled to about 311 on the first come, first serve kind of service. The number was determined using the Rausoft formula, 95 confidence interval, margin of error 5% and 50% response rate. We worked out the needed number to 311. Pain satisfaction and American Pain Society pain outcome questionnaires were adapted and administered by the researcher. We also reviewed the delivery notes to just ensure and make sure that this pain was not given. Yeah, and then data analysis was achieved through SAS Institute, the US one, release 9.4. We used the 4-point Likert scale to categorize those who were satisfied and not satisfied. And we obtained the ethical considerations. In South Africa, you cannot do any research without ethical consideration from the National Health Research Database, where you register, and that was our number. GP stands for Gauteng Province, 2017-11-002. And then we also had ethical approval from the University of Witwatersrand, and the reference number for that is M170608. So with these two, we were ready to go. But above that, we needed also to get approvals or permissions. We needed to get permissions from the District Health Services Chief Director, where the study area fell in the area it fell. And then we also had to get another permission at the facility manager, at the facility itself. So this is how we achieved our ethical issues. Not only that, we obviously had to obtain consents. We had to give them study information, leaflets. We had to ensure that we had trained people could help us with some translations and reading to mothers, because their levels of education were different. We also involved the nursing on the facility, that they understand that they study going. They could help us with the channeling these mothers when they presented on the 3rd day for review. Yeah, so then the mean age, as said earlier, was 26.9 years. 90% were indigenous Sizulu speakers, with 2 children and some secondary education. Moderate pain was experienced by 49.2% of participants. There were also other options, such as some of them used the herbs and the prayer, which were used in about 55.3%. Deep breathing, 26.2%. Walking about 22%. Massage of some form or the other, 21%. And the prayer alone, 14%. We had we put your herbs and prayer there, and then we separated it and did the prayer alone. Effective pain relief was demonstrated. Sorry about that. Yeah, effective pain disease was demonstrated in 53.1%, while satisfaction was 56%. In the questionnaire itself, it mentions when you look at the visual questionnaire for pain, it shows you whether you have the least pain and the worst pain. So the least pain, you can see here, the table above shows that almost half, 49.2% of the participants felt that the least pain they experienced was nonetheless moderate in nature. After interrogating them and discussing with them, and they indicated, you can see 49.2% there who experienced moderate pain. And then the worst pain ever experienced, on the visual, you've got no pain at 0 to 10 with the worst pain experience. So in this case, the above table shows that under half, 43.7% of the participants felt that the waist pain they had experienced was very severe. And then when you look at other options of non-pharmacological options, you have deep breathing and the walking, massage, prayer, heat, listen to music, relaxation, distraction, code pack, imagery and visualization, and the total number of times mentioned. We found that overall, when you looked at the rest of Africa, particularly in West Africa and all that, these are all practiced, and they normally don't use the normal analgesics. And a lot of our women, generally from literature, they depend on a non-pharmacological kind of approach. But we wanted to see that for us, how effective was that? Because we had the means of using pharmacological means, and we didn't see any reason why it should just be relying on non-pharmacological. In any case, the above table depicts the most frequently used non-medical pain relief methods, with deep breathing being the highest at 26.2%, walking 22%, massage 21% being the most popular. So the walking about, deep breathing and walking about, normally quite common with midwives. You know, they actually help the mothers to do this and help them to walk about as long as they are quite early and all that. And then the massage depends on who massages you. If you're accompanied by a spouse, we do not really allow spouses in the delivery bed because of the physical constraints. But in early labor, yes, they can be on their bedside and support them in that way. Table 4 here shows the ratios and confidence intervals as significant predictor of satisfaction. When we looked at the associations between social demographics and the satisfaction, we found that patients with one live birth were 11.5 times more likely to be dissatisfied compared to patients with 4 live births. This could also attribute to the fact that those who have a one live birth could be quite novices when it comes to delivery. And those with more births may have had a greater experience. That's why they will probably be much more satisfied. That could be only our explanation, supported by several literature, actually, sources, that those who've got those who have more live birth, they tend to be more satisfied. Patients with 2 more satisfied with pain control. Patients with 2 live births were 3.8 times more likely to be satisfied compared with those with 4 live. Patients with 3 live births were 2.4. So as we have seen, those who had the more live births, particularly 4, were much more satisfied than others. Figure 1 shows that most participants had 2 live births and the minority had at least 4. This just shows now the proportion. How many of our participants had how many live births? So most of them had 42% actually had 2 live births. Then we have followed by the minority at least 4 live births. You know, so there were few who had more births than those who had 2. So then these findings confirm and also show to us that, or suggest that in our community, the non-pharmacological treatment options were actually effective in managing labor pains, and that the moderate pain experienced by a significant proportion may signify the need for additional pharmacological treatments. They did not attain full pain control. There was you remember 56% were satisfied, so there are at least 43-point-something% who really needed to push up. So we think that with this kind of information, it will be important to convince our policymakers, our facility, that they need to, policymakers have already done the guidelines, but I'm talking about now our facility or the district level, that we need to ensure that there is more clinical governance around the issues of implementation of analgesia and labor. So the association between low parity and satisfaction warrants further research. We know that the general picture that those who have one live birth or low parity tend not to be satisfied. Their pain seems to be like out of this world. So because of that, we feel we need to do more, maybe a qualitative study to understand the reasons why this kind of low parity mothers experience so much pain. Other than just the thinking of that, maybe because they are not experienced, there could be other reasons. So we advocate further research there. So what do we then recommend from all this? In-service training of midwives and doctors. We know that our center runs 24 hours, and in each shift, you've got about 3 to 4 midwives. If you're delivering 2,000 per month, that's quite a substantial number. So we've got about 3 to 4 at every shift. And there are also doctors who work 24 hours at that center. It's got a CHC side where the doctors work. Although they do not present themselves much in the midwife obstetric unit. When they've got referral problems, then doctors could be consulted to assist. But generally, these doctors pay much attention to the primary healthcare aspect in terms of acute conditions. So there are also doctors there. We need also to conscientize them and educate them about this pain control. We need to empower women through health talks, especially when they are waiting for service in antenatal clinics, through groups and classes, COVID allowing. We need also to send messages. We need to leverage on technology to try and there is what is called Mom Connect in South Africa, which we use for our maternity cases. So we will be encouraged to send those messages to them about pain control when they're in labor. Then we also need to talk about improved clinical governance and supervision with the ongoing audits and quality improvement projects around pain control and quality of care while in labor. Yeah, so those were the top 5 references, although the references are around 20 and can be provided as long as you request them. And I will end here for today. Thank you very much to our healthcare workers in terms of the resilience with maternal and health issues as well as the COVID. Thank you very much. I'll end here. Thanks.
Thank you, Mr. John. It was an awesome presentation. I will request the participants to raise the questions in the QA session or in the chat box. And we have also enabled the poll for voting. So you can also vote for Mr. John. We have a question for you, Mr. John. What are some of the examples of these non-pharmacological inventions?
Yeah, sorry. I think I did show in my slide that examples are many. One of I was giving examples of deep breathing. Non-pharmacological means you are not using drugs, you are not using medication to control pain. It means that you are using other options. So some of those options are options like deep breathing, which midwives tend to tell our mothers to do. They take deep breaths when the contraction comes. So deep breathing is one of them. Walking about. Instead of sitting still and experiencing all the pain, you walk around so that you sort of you are distracted. Evidence all over the world has shown that tends to assist with pain. Immediately you are in one place, not moving, the contractions become so severe. We also have massage. You can have your significant other to massage you. Can massage you on the back, can massage you on the tummy itself. As long as it's early in labor, obviously, then you can do that. There are also other forms. We spoke about prayers, that quite a number of our mothers go into prayer. They They pray so that the experience could be better. By so doing, it helps them to have less pain experience. We also saw in the presentation that some use herbs. You know, herbs. Herbs is one of, especially in across Africa, we use a lot of herbs, and that is what some of them use. And also particularly positions. I think as I showed the slide, I showed on the other side, there was a mother sitting on a big ball, you know, playing with the ball, you know. She sits on that as the contractions come, she moves with the ball and all that. There's also, you know, all those kinds of interventions. Different positions affect pain differently. So that we encourage them to do that. And that's where empowerment comes in. They need to be taught while they are in the antenatal time, that when you go in labor, this is what you need to do to minimize pain. I think we are not doing enough in terms of empowering our mothers, particularly in where we've been involved. Thank you.
Thank you for the brief. We have one more question for you, Mr. John. Did you review any documents on community medicine and its relation to maternal health?
Yes, you know what you do. Part of my job is that I'm in the district clinical specialist team. Actually, I'm the coordinator for that team. It means that in a health district of about 4 million, my health district has got 4 million, it's got 1 tertiary hospital, it's got 4 regional hospitals and 1 district hospital, which I also assist to coordinate as part of my job. One of the tasks we are supposed to do with the clinical specialist team, it's got a group of specialists. There's a family physician who is myself. We have got an obstetrician, we've got a pediatrician, and the 3 specialists have got the advanced nurses. So I've got advanced PHC nurse, advanced pediatric nurse, advanced obstetric nurse. That is throughout South Africa, we do that. And our main target is to try and improve maternal and child health indicators. So we work a lot with the mortalities, you know, for babies, for mothers. We work a lot with the quality of care of mothers. We actually go to hospitals and facilities. We hold the maternal and the mortality meetings on a monthly basis with every hospital, every facility. We've got 94 primary healthcare facilities. And we've got 12 community health centers where one of these studies took place, catering a very big population. So we go to those centers, even to this center I'm talking about, we look at the deliveries, the numbers of deliveries, how many were transferred or referred, how many of them, you know, any mortalities or morbidities. We look at all that, and it's well documented. Also, we work with the other hospitals and devise a way of improving referrals, because that's one of our biggest problems or challenges. Referrals in relation to the availability of ambulances. We also did in this study review delivery notes. So we looked at every case of those who participated, from the time they came in to the time they left, to the 3rd day they came to see us. All that transpired during that process. So we did, yes, we did look at a lot of those things. Thank you.
Thank you, Mr. John. We have one more question. Some cultural norms in Africa are not favorably disposed to use of pain relievers for women in labor. Was this seen in the study? And could that explain why it is not seen as a necessary medication to administer to these women?
Yeah, that is correct. That is correct. In some cultures, we noticed from literature that in some cultures, they want to experience the pain. You know, it's a deliberate move to experience the pain. But, you know, we are moving towards the individual liberalism, where people's rights are very important and the quality of care is important. We know that in some cultures, women feel, particularly we saw that in the Black cultures actually, women feel that if they experience the pain, then it's more deserving, you know. But it shouldn't be like that. That's why we need to empower our women, that it's not a punishment. To have a baby is a sweet thing, should not be a punishment. We know that it's very difficult to change culture. And we know that the culture, you know, runs deep. And we can only do that if we continuously engage our mothers, try to empower them, educate them, give them information, and still make them take choices. If at the end we've given them the medications, we've shown them all the medications which we have, which we can give them while in lab, and they still say, no, I still want to go through it. We respect that. But your observation is, whoever asked that question, the observation is correct. That is what it is about. You know, some cultures want to experience that pain. But in 2022, as I said, we need to empower our women to make correct choices. If they still insist they want to go through it with the pain, we respect that, but we also document it. If we didn't document it, that's why we reviewed the notes. It was nowhere documented that the mother chose to undergo pain. If it's documented and the mother chooses to undergo pain, we'll respect that. That's what it is. We put the patient at the center of our practice, and as long as we give them information and choices, they can ultimately choose what they want to do. And that is the quality we are talking about. Thank you.
Thank you so much, Mr. John. There's one more question from Ms. Rebecca. So is there any advantage to the mother and the baby if a C-section is done before onset of a labor pains?
Yeah, that's quite a very separate question. I've spent 17 years. I was spent 17 years working in a rural district hospital before I moved to this urban area. And yes, you can do. If mothers, while they're in antenatal, they choose to say they want to undergo a cesarean section for whatever reason. It could be that they don't want to experience pain. It's happening a lot in private practice, happening a lot, especially with educated mothers. They want to choose the date to be convenient to them when they actually deliver. They want to choose the date. They've planned their leave, especially the working mothers. So they can elect to have that cesarean section, depending on capacity. In public sector, we do, in some of my regional hospitals, we do cesarean, 1,000 cesarean sections. You know, you can do about 1,000 cesarean sections in a month. You know, and how many staff do you have? Maybe 30 or 40, maybe, yeah. So that is actually the whole district. Yeah, we do about 1,000, which means one can do maybe 200, 400, and that is like 40% of their deliveries. So cesarean sections are being done, but the capacity is not always there. So if they don't want to go through pain and they elect to do a Caesar, who support that if capacity allows. But some others, yes, so they would go that route. Remember, a cesarean section is expensive. You know, it's not a normal delivery. Normal delivery is much more cheaper than a cesarean section. So it eats on the resources, so that we only leave a cesarean section to where it's clearly indicated. You know, but as I said, in private practice, they can arrange with their doctors and they can do cesarean sections as they wish. Thank you.
Thank you, Mr. John. I hope like all the participants having benefited your presentation. I request you to put down your email address in the chat box so that the participants will be personally contacting you for any queries.
Okay, thank you very much. I'll do that.
As we're running out of time, there are a few more questions from the participants. I hope you could answer that like personally to them with the email.
Okay, thank you.
Thank you so much, Mr. John.
Thank you.